episode of Making the Rounds, we'll be discussing diagnostic advancements for prostate cancer, medical treatment options, surgical interventions, and prevention strategies. To learn more about these topics or other oncology-related services provided at Banner MD Anderson Cancer Center, please visit bannerhealth.com/cancer. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in. If you're a regular listener, welcome back. Joining me today on Making the Rounds is Dr. Alex Bowman, a medical oncologist specializing in genitourinary cancers at Banner MD Anderson Cancer Center, and is the co-director of the genitourinary cancer program at Banner MD Anderson Cancer Center. Thank you for joining me today, Dr. Bowman, and welcome to Making the Rounds.
Thank you very much for having me. It's a pleasure to be here.
Well, we're excited to have you. Dr. Bowman, tell us a little bit about yourself and your program here at Banner MD Anderson.
Sure. So I'm a medical oncologist. That means I treat cancer with generally medications, things like chemotherapy, immunotherapy. I work closely with my colleagues here in urology and radiation oncology, particularly in treating prostate cancer. I've been here with Banner MD Anderson Cancer Center for a little over 3 years now, and in the role of co-director for the genitourinary program here, along with Joseph Mashney, who's one of my urology colleagues.
Wonderful. Well, thank you for being with us today, and we're really excited about having you on our program today. So, Dr. Bowman, let's start with some background on prostate cancer. Prostate cancer is one of the most common cancers in men, particularly as they age. Can you give us an overview of prostate cancer and why it's a significant health concern for men?
So let's start off with just kind of what is the prostate. So the prostate's a small, approximately walnut-sized gland, kind of located at the base of the bladder around the urethra. Its function is to help create the seminal fluid that is produced and utilized during ejaculation. The prostate can develop a cancer called an adenocarcinoma, and in fact, it's the leading cause of cancer in men. 300,000 men every year are diagnosed, and over 35,000 men will die from their prostate cancer every year. The average age at diagnosis is in the late 60s. But that being said, about 1 in 5 men who are diagnosed with prostate cancer are diagnosed before the age of 60, so it can occur in younger men. And unfortunately, as I mentioned, 35,000 men will pass away from the disease. That means that we're not able to cure everybody, and diagnosing it before it has spread and while it's still treatable with intent to cure is very important.
What are the common symptoms of prostate cancer that patients and medical professionals should be aware of?
So it can be a little bit tricky because a lot of times as men age, they develop a little bit of benign enlargement of the prostate, which can lead to some urinary symptoms, such as going to the bathroom more frequently, weaker stream, getting up and going to the bathroom overnight. And a lot of men will kind of notice these symptoms, kind of write them off as symptoms of aging. Maybe a lot of other men in their family have had these, or they've seen other men and talked to other men who've experienced it. But these can also be symptoms of prostate cancer. Basically, if there's a tumor that's enlarging in the prostate, that places some pressure on the urethra and again can cause those urinary symptoms. Now, in some cases, you'll develop a little bit of blood in the urine or even blood in the semen. And those are things that are not normal under any circumstance, and you do need to be evaluated generally by a urologist if that's something you're noticing. If the cancer does spread and can show up in other areas of the body, and the bones is an area it likes to go to in particular, you can get aches or pains caused by that. In some cases, folks will develop weight loss, loss of appetite, kind of generalized systemic symptoms that are a little bit nondescript. But unfortunately, a lot of the time, folks don't have any symptoms at all. And so that's one of the reasons why prostate cancer screening and basically trying to look for and catch the disease before it causes problems or before it causes symptoms is important.
Is underdiagnosing prostate cancer a concern?
Well, sure. As I mentioned, there are 300,000 men that are diagnosed. 35,000 of those men will pass away from their disease. And that obviously means that the vast majority of people diagnosed with prostate cancer won't. And part of the reason for that is when we diagnose it before it has spread, before it has left the prostate, that allows us to tailor the management of that cancer, of that diagnosis, based on findings about the aggressiveness or the risk to that patient. So there may be people we diagnose with a low grade, kind of low, what we call a Gleason score cancer. And in many cases, we'll monitor those patients and a lot of them won't need treatment. So prostate cancer is one of those cancers where it has a very wide spectrum of behavior from, very slow moving, indolent, and not going to cause problems for the most part, to very aggressive. And we only are able to kind of put you into the right category if we know what's going on. So it's kind of contingent on us finding it, making that assessment while the cancer is still localized to the prostate, so that if we do need to do these more intensive treatments such as surgery or radiation, we're doing those early enough that we can make a difference and change this from a cancer that eventually with time would spread and would claim the life of the patient to one that we can at that point cure. African American men actually are at higher risk, and so we do, start screening a little bit sooner for them.
Dr. Bowman, thank you for that overview. I want to shift a little bit, and I want to talk about treatment options. So as we're talking about screening, we're talking about the advancements in imaging and the next step in, as you're talking about biopsies. What are some of the advancements in treatment options available for prostate cancer patients who are treated at a Banner MD Anderson Cancer Center facility?
Sure. Whenever we're approaching a patient and we've, diagnosed them with prostate cancer and it's a type that's going to require treatment, we always want to make sure everybody has kind of all of the options that are available presented to them. There's not necessarily a best treatment. There are often many different options that can ideally get the patient to the same end goal of being cured by the cancer or cured of the cancer. But there are kind of different pathways, different toxicity risks with those treatments. So it's important to have a kind of active and informed conversation with the patient about what the options are, what the risks and benefits with each of those options are. And then kind of make a joint decision about which one to move forward with. A very standard option for treatment is surgery, so radical resection of the prostate. This is typically done by a urologist. That would involve removing the prostate and often a couple of lymph nodes within the pelvis, just to predominantly make sure that we're kind of adequately staging, evaluating those lymph nodes for evidence of whether or not the cancer has spread. External beam radiation is a very commonly used treatment modality. That's where radiation is applied from the outside in towards the prostate. That can be done both to the prostate as well as lymph nodes within the pelvis if they're found to be involved with the cancer or suspected to be involved. Another twist on radiation is something called brachytherapy. Brachytherapy is basically a way to apply radiation in the operating room. Needles are placed in the prostate and can be kind of targeted to areas where there are tumors kind of specifically. And then radiation is introduced through those needles kind of all in one go. And sometimes that is combined with external beam radiation to kind of hit it from multiple angles. For folks who may have a small or a low-grade prostate cancer, there are other kind of local therapies. One of those is called HIFU, or high-intensity focused ultrasound. This is basically a way of pointing ultrasound waves at a tumor to basically cook it, and that is something that's offered here.
Thank you. And when we're talking about these surgical interventions or radiation oncology treatment, are these the first step and then the medical oncology and?
Generally we have a what we call a PSA clinic, and this is for men who have been found to have an abnormally elevated PSA. We would typically meet with the patient, kind of talk about the options for diagnosis, usually in that case get an MRI of the prostate, typically depending on the results of the MRI and whether there's enough suspicion to warrant a biopsy. Then one of our urology colleagues would do the prostate biopsy, often using that MR guidance to make sure we sample the appropriate areas. If you're found, unfortunately, to have prostate cancer on that biopsy, you will typically meet with a multidisciplinary team that is composed of a urologist who's specially trained in urologic cancer surgeries, including prostatectomy, as well as a radiation oncologist. And we try and do both of those visits at the same time, so you can get kind of multiple opinions on kind of different options for treatment if treatment is indicated. After the surgery, if everything is out, the cancer is completely removed, you then hopefully have an undetectable PSA afterwards. Usually you're just followed just to make sure it doesn't come back. A lot of times folks will go through some what we call pelvic floor rehab and kind of sexual health rehab afterwards to kind of combat any lingering symptoms from surgery, which could be things like incontinence or erectile dysfunction. Again, hopefully if the cancer is gone, then there's generally no more treatment from a cancer standpoint. Where I do get involved quite often is for folks undergoing radiation. When we do radiation to the prostate, for most patients, unless it's a very low risk, less aggressive cancer, we are going to use testosterone deprivation therapy along with the radiation. And we do this for for a couple of reasons, but predominantly because the prostate cancer cells need testosterone to grow. It acts as a growth factor for them. And when we take it away, not only does it put the cancer basically into kind of a quiescent or a hibernation state, and you'll see that reflected in declines in the PSA and actually shrinkage of the tumors, but it also makes the prostate cancer cells more vulnerable and susceptible to the damage the radiation is going to do to them. And so we can increase our cure rates with radiation by utilizing hormone deprivation, testosterone deprivation along with that. Usually I, as a medical oncologist, will help manage the medications that are used to achieve that low testosterone state. We'll also help work on managing the side effects that can go along with that.
So as we're talking about testosterone, it's triggering our previous conversation of hormone therapy. Can you discuss in more detail the role of hormone therapy in the treatment of prostate cancer? And how do the emerging treatments such as immunotherapy fit into the current landscape of prostate management?
Sure. So as we alluded to, testosterone is a very important hormone for prostate cancer. It utilizes it as a growth factor. Basically, it allows prostate cancer cells to replicate their DNA and to reproduce. And so when you deprive them of that, it will put them kind of into a dormant state, into a remission state in a lot of cases. And we use it kind of in two main circumstances. One, again, as you know, in folks who are receiving radiation treatment to their prostate, if the cancer hasn't spread, we will typically do some duration of hormone deprivation ranging from 6 months to 2 years to handicap the cancer, make it more susceptible to that radiation, and hopefully increase our chances of cure. And then the other circumstance where we very commonly use hormone deprivation, testosterone deprivation, is in folks whose cancer has already spread. And unfortunately there, we're not so much treating them with the intent of cure, unfortunately. We're treating it, trying to control it, prolong their life, slow the cancer down. And their hormone deprivation, testosterone lowering drugs is a very important and probably kind of the first and most critical tool in our toolkit. Eventually, the cancer becomes what we call castrate resistant. At that point, we have to start to add in other treatments, things like chemotherapy drugs, immunotherapy, kind of these targeted radiation therapies to the management of the cancer. And, you know, touching on immunotherapy, that's a very hot topic in cancer care at the moment. A lot of the new drugs and new treatment strategies that are coming out are immunotherapy medications of one form or another. Most of the time when we're talking about immunotherapy, we're talking about a class of medicines called immune checkpoint inhibitors, which are medicines that basically shut off a signal that your body and the cancer cells use to deactivate the immune cells when they show up. Your immune system is designed to try and find and kill cancer cells, but the cancer cells have the same blueprints as your normal cells, so they can express the off signal to the immune system just as well, and in a lot of cases better than your normal cells can. Those medicines block that. That class of medicines, that's things like Keytruda and Opdivo, you're seeing commercials for those if you're watching football games, don't tend to have much of a role in prostate cancer management. Prostate cancer does not typically kind of engage with the immune system to that level. There are other immunotherapy strategies we do use. So there's something called a dendritic cell vaccine, it's a medication called Provenge. This basically uses your white blood cells, or a subpopulation of them called dendritic cells, where you remove those with a what's called apheresis procedure, kind of incubate them with growth factors and medications to kind of increase their aggressiveness, infuse them back into the patient. And that has been shown to help control prostate cancer, so we will use that. And there are investigational strategies using what are called bispecific antibodies, basically cells that grab onto the prostate cancer and grab onto an immune cell and bring them together. That's a strategy that's currently being investigated, so there may be more role for those specific medications in the future.
So looking towards the future, Dr. Bowman, are there any promising new developments in the field of prostate cancer treatments that you can share with us, or that you're working on currently?
Sure. There's a couple, and actually, there's been a lot of development and advancement in prostate cancer care over the last 5 years or so. One of those has been utilizing a protein that's expressed on prostate cancer cells called PSMA. We can exploit that protein marker in a couple of ways. I didn't mention it earlier, but oftentimes we'll use a PSMA-directed PET scan as part of the diagnostic workup. It's our, at this point, most sensitive way to try and evaluate for whether the cancer is spread, and at least hopefully ensure that it hasn't before we go through some of these more intensive treatments like surgery or radiation. And so right now, how that's done, there's an FDA-approved therapy called Pluvicto, which utilizes that same protein along with a higher energy radiation particle called lutetium-177. And so instead of dragging a particle that the detector can see right next to the cancer cell, it's going to drag a particle that's going to sit there and emit radiation for the next week or so, doing damage to the DNA in the cancer and hopefully treating the cancer that way. And that's a treatment that's been available now for about 2 years. That same PSMA marker is also being utilized to try and target the immune system. So one of those immunotherapy things that's in development that I mentioned are what are called bispecific antibodies. And so if you can attach an antibody to the PSMA protein, and the other end of that is going to grab an immune cell, basically it'll just kind of put them right into direct contact with each other, and that increases the likelihood the immune system is going to start to go after the cancer. So that's something that's in development right now. There are clinical trials going on. We are in the process of trying to open one of those trials here, so hopefully that happens sooner rather than later. There are increasingly other kind of molecularly targeted strategies. So as we're doing more genetic profiling of these cancers, we're finding more and more mutations which we can target with medications to exploit those mutations. Generally, the mutation will cause a problem in some kind of cellular function that if we kind of lean into that or make that problem worse, say the cancer has a hard time doing DNA repair, and we have a medicine that makes it harder to do DNA repair, we can kind of target that or exploit that alteration in the cancer cell. And so a lot of the developments that we're looking at in the future are that kind of what we call targeted therapy.
That's exciting work. And you guys, your team here at Banner MD Anderson are part of those upcoming future clinical trials. And as you mentioned, hopefully we'll be able to bring those here to the Valley.
That's correct. Yeah, we're working on that. We're working on opening a bispecific antibody trial. We're working on opening, we have Pluvicto, the radio pharmaceutical therapy. We're working on a trial that's going to look at using a separate but similar approach a little bit earlier in the treatment of prostate cancer. And then, we are opening a trial that's going to use that targeted therapy, a class of medicines called PARP inhibitors, also fairly early on in patients who are newly diagnosed, whereas right now we only use that once they've already been exposed to hormone deprivation and usually a couple of years into their treatment.
Exciting work. Thank you. Thank you for sharing that with us. And thank you, Dr. Bowman, for being a guest here on Making the Rounds today. This conversation has been incredibly insightful, and I hope our listeners feel the same. We appreciate your expertise in this field and in this field of medical oncology, but in particular genitourinary cancers, and in this conversation, prostate cancer. So thank you for being here today.
It was a pleasure. Anytime.
Thank you for joining us here today. And if you found this conversation as informative as we did, please subscribe to our podcast for more discussions on important medical topics. To learn more about Dr. Bowman and the prostate cancer treatment or other oncology services provided at Banner MD Anderson Cancer Center, please visit bannerhealth.com/cancer. Thank you for listening, and we'll see you next time on Making the Rounds.